about. So let's go back to the lab slide box here. And we did brain, we did adrenal, we did bone, we did appendix. And we got a few more here. Here, let's do another example of inflammation, okay? This is the world's most normal gallbladder. You might remember that a gallbladder has a classical columnar mucosa. It has a nice thin wall, and it also has some muscle in it, and then it has a serosa. You could even see some of these little tiny mesothelial cells of the serosa. This is a normal gallbladder, okay? Now I'm going to show you something interesting. I'm going to show you another gallbladder, and I'm going to have you make the diagnosis. I'm going to show you another gallbladder, and you're going to say, hey, this doesn't look like the other one did. You're going to say, you know, there's something wrong with this. It looks like it might be a little edematous. There's some hemorrhage. There are some inflammatory cells here. But what I'm going to ask you is, these inflammatory cells that you see within the gallbladder wall and the gallbladder muscle, this is strictly an opinion poll. This is not a medical question for a yes or no answer. Are most of those inflammatory cells lymphocytes or neutrophils? That's the question. Just be honest, because if some of you say neutrophils, guess what? You'll be right. But if some of you say lymphocytes, you'll also be right. So that's why some pathologists, if they looked at this gallbladder, they might call it acute and chronic cholecystitis. Okay? Now, what do you think would be more dangerous to the patient? An acute cholecystitis or a chronic cholecystitis? It's an acute because now there's more extensive damage and weakening of the wall. Chronic cholecystitis is very, very, very common and usually not even clinically apparent. Okay, so good. We did gallbladder. I'm going to show you another interesting thing here too. In fact, this is going to be kind of a trick question at first. Now that we're kind of getting used to things, you're going to say, oh my God, what is this? And then some of you might remember that the cerebellum looks like this. Because remember, in the cerebellum, it's kind of like the opposite of the cerebrum. The white matter is on the outside of the folio, and the more cellular gray matter is on the inside. Like the opposite of the cerebral cortex is the cerebellar cortex. And you can also say, rather than these things being called a gyri, they're called folia now. So you go, okay, so it's a normal cerebellum. Let's move on. But wait a minute. Take a look at this space here where the meninges are between the folia. You got a lump of stuff there. You got a lump of something there. You got a lump of something here. You say, wait a minute, that can't be an artifact. Let's zoom in on that and let's see what it is. So let's take this one. Can I ask you a question? I just want to know if anybody would like to just take a wild stab before I say anything as to what this is. Is it a parasite? Is it cancer? And anybody want to take a guess as to what this collection of cells are? Well, towards the periphery, you can see some lymphocytes. You can see a blood vessel in it, but that might be part of the meninges. You see a localized collection of cells that are not lymphocytes because they have a lot of cytoplasm, but they also form multi-nucleated giant cells as well. So I know that somebody wants to tell me the name of this particular type of inflammation. It's not acute. It's sort of chronic, but you have mostly macrophages forming localized clusters with giant cells. Yeah, that's a granuloma. That's granulomatous inflammation in the cerebellum. So in all honesty, all you could say is that this is a granulomatous meningitis or a granulomatous cerebellum, whatever you want to call it. But let me ask you another question. Is the inside of this granuloma still have viable looking cells with nuclei, or does it look like it's necrotic? In other words, are the cells just as visible on the inside of the granuloma as they are on the periphery of it? Yeah. So this is a non-caseating granuloma. Now, I know that the clinical people and the surgeons have been kind of brainwashed into thinking that non-caseating granulomas are not tuberculosis and caseating granulomas are tuberculosis. Well, if you want to think that way, you can, but in all honesty, a non-caseating granuloma could be any granuloma. And this particular non-caseating granuloma is totally typical for sarcoidosis. So these are non-caseating sarcoid granulomas. Look, there's another big giant cell. There's a big giant cell. There's a big giant cell. It should almost be a knee-jerk reflex. Whenever you see a collection of cells and there's all of these multinucleated giant cells with them, you can probably almost instantly call these things granulomas. Now, even though this could be tuberculosis or any granulomatous disease, a fungal disease, for example, it could be tuberculosis, or it could be the number one non-caseating granuloma disease in the body, which not only involves the lung like TB and fungi, but it can involve everything. This is sarcoidosis, okay? But we don't have to worry about that yet. We're going to get a lot on it later. Let's go to the next slide here. And I'm going to show you, I'll tell you already, I'm going to show you another granuloma. Okay? You could recognize this as lung almost instantly. See, alveoli. But you can also see some granulomas here too. There's one, there's one, there's a big one. And you know what I'm going to do? I'm going to blow up one of them, like this one. Now let me ask you this. In this particular granuloma, would you say that the inside or the center is kind of granular and crunchy and not quite as viable or visible on the outside? And if you don't want to answer that question, let's take a look at the other granuloma that we saw, you know, the one that was bigger, because that's going to be down here. Do you see how the whole inside of this big granuloma is necrotic? In other words, you can hardly even make out any cellular outlines. This is necrotic debris. This is coagulation, or I guess because if you thought it was tuberculosis, you could call it caseating necrosis or caseous necrosis or caseating granulomas. So here's the quiz question. Because this is in the lung and it is a caseating granuloma, what is the first disease that comes to your mind? You got it, TB. Thank you, whoever you are. I don't know who the smart people are that are giving me the right answers. I prefer not to know who they are. But I even enjoy more the people that give me the wrong answers, because that means they're going to learn something. Okay, now, but in all honesty, all you could do is call this, diagnose this as caseating granulomas. But let's say the surgeon removed this part of the lung, or it was an autopsy, or maybe he removed it because he thought it was a tumor. And then you took some of this stuff and you cultured it, and it grew Mycobacterium tuberculosum. Then you'd know it was tuberculosis. Or you did a stain, an acid-fast stain on it, and you could see tiny little red rods, and then you would know it was acid-fast necrotic caseating granulomas, which is tuberculosis. Okay, we mentioned this before when we talked about granulomas as one of the inflammatory patterns, but I'm going to mention it again. I want everybody to write down the classical diseases which form granulomas. I'm going to give you 4 of them, and I'm going to see if you could tell me all of them before I even start mentioning them. Well, somebody already said TB. That's one. We saw that sarcoid was another. With fungal diseases, whether they're superficial or deep systemic fungi, they also very characteristically can form granulomas. And what's the 4th thing? Did you ever assist in a surgery and you sutured up somebody? What do you think happens to those little suture fragments? They're attacked by localized collections of chewed up by macrophages. They call them stitch granulomas or foreign body granulomas. So those are the 4 things: foreign bodies, TB, fungi, and sarcoid. Whenever you see a granuloma, instantly think of those 4 things. I'm going to go to the next case now. And, I'm going to show you the world's most normal cardiac muscle histology. In fact, this happens to be from a heart. And you can see a pericardial surface, and you can see some trabecular muscles here. And I'm just going to show you Histology 101, the classical features of normal cardiac striated, cross-striated muscle. They have nuclei, often in the middle of the fiber. They interweave with each other. And maybe, just maybe, if you're lucky enough on H&E, just maybe you might see some striations going this way. I don't see striations, but I do see fibers. I see the nuclei in the middle of the fiber, and I can see that some of these fibers kind of interbranch with each other. And this is the world's most normal, and there's some blood vessels, the world's most normal cardiac muscle from a ventricle. I guess if you looked at the atrium, it would show the same thing, wouldn't it? Now we're going to go to another heart, and we'll probably go to this one. And once again, well, first of all, you see an artery in the epicardial fat pad that looks like it's almost thrombosed, or perhaps 90 or more percent occluded. And then you can see some muscle fibers, but there's some white stuff in between it too. And the fibers don't really look totally, yeah, well, here's some fibers. Here's some fibers cut longitudinally. Here's some fibers cut on cross-section. And you can also see that these fibers are being infiltrated by inflammatory cells. Some of them may be neutrophils, but in my opinion, most of these inflammatory cell infiltrates are macrophages and maybe even some blood vessels. So this is the stage of inflammation where you might have the ingrowth of blood vessels, the organization phase, okay? In other words, you could call this an organizing infarct, or you could call it an acute infarct because it's probably no more than about a week old. Now, the reason why I'm showing this is because when you look at the texture of this granulation tissue and you compare it to the texture of the thick muscle fibers, it's not nearly as strong. So an organizing infarct represents the stage in the life of an infarct where the wall could rupture. And what happens if a myocardial wall ruptures? Well, then you get a pericardium that's going to be filled with blood. It could compress the heart, cause tamponade, and that's the most dangerous time for a infarct to rupture is about, let's say 5 to 7 days, which is still relatively acute. Now, I'm going to show you something else. I'm going to show you another heart, and we're going to look at this one. And you're going to say, well, this doesn't This looks pretty strong. It's kind of pink and dense in all areas. Well, maybe, but take a look at the nature of the pinkness, okay? These are the fibers, but this is dense collagen tissue. If you stain this with trichrome, this would be green. So now we have a heart that has some residual, perhaps viable cardiac muscle fibers, but we also have a big area of scarring. So you would call this perhaps an old or a remote myocardial infarct. Now you have strong fibrous tissue between the fibers, and it doesn't represent too much of a chance of it rupturing. Okay, this is a scar. This is how myocardial infarcts heal, with fibrosis. And if you don't believe these are fibroblasts and these are tissues, I'll even blow it up a little bit more. Okay, you can see there's the nuclei within the center of the fiber. And these are fibroblasts. There's a fibroblast, there's a fibroblast, there's one, there's one. This material here is predominantly collagen, this lighter pink stuff, and this darker pink stuff looks like they're big, fat, myocardial, cardiac, striated muscle cells. So we talked about infarcts extensively at one of our webinars, and now we're seeing a real example of it on a glass slide. Okay, I'm going to show you the world's most normal liver, and I think you should recognize it pretty quickly, even if you don't remember the names of all the cells. But even though this is stained kind of lightly, what you can recognize is that certain veins don't have any connective tissue around them, and certain veins do. This is a portal triad. This is a portal triad. This is a central vein. This is a central vein. That might be a central vein. I'm going to show you the so-called hexagonal pattern. So because you're seeing almost like hexagons in here with portal areas surrounding central veins, you can say this is a normal hexagonal portal architecture. The blood goes from the portal area, which has the portal vein, the hepatic artery, and the bile duct, through the sinusoids into the central vein, and then into the hepatic veins. This is your functional unit. You call it a lobule if you want. Now, I'm going to show you another liver. Oh, also, take a look at some of these cells. I'm going to show you, when you look at the sinusoids, you can see that there are nice little spaces between these cords, and they all look like they're hepatocytes. Now I'm going to show you another liver right now. We talked about one of the most common types of liver diseases found in alcoholics, in diabetics, and in fat people. Okay, this is called a fatty liver, and I think you'll recognize it instantly as fat, because now you don't really see those nice cords. It looks like almost every cell it looks like almost every cell has little vacuoles inside of them. And some of these vacuoles are even bigger than the cell, but for the most part, these vacuoles are within the hepatocytes. So you call this a fatty liver. You can also call it steatosis. You can also call it fatty change. You can also call it fatty metamorphosis. Okay? And because most of these round fat spaces are within the cell, you also call it microvesicular steatosis, because most of the fat are small lobules within the cells. If you saw a lot of areas in which fat looks like it was like bigger than a cell, like maybe here or here or here, then you call that macro. But as you might guess, the macro is more severe than the micro, and this is predominantly microvesicular fat or microvesicular steatosis. Not that it really matters, because fat is fat, but in the early stages, the vacuoles are likely to be smaller and intracellular, And in the later stages, the fat accumulation could be much bigger than the liver cell. Okay, I'm going to show you another simple liver case here. And this is going to be a lot like the brain case that I just showed you. Now you're going to say, well, how do I know this is liver? Well, let's blow it up more and we'll figure it out. Doesn't that look like liver? Well, you can see some kind of area here, but what you're seeing like here and here, and even in between these veins are infiltrates of inflammatory cells. See that? And they go beyond the portal areas. So if you have a liver and it has inflammatory cells, how about if we call it hepatitis? And that's what this is. Of course, if it was even more severe, you might get this inflammation like all over the liver. So just to keep things simple, we're not going to say this is due to a certain virus, or we're not going to say this is due to alcohol. But we are going to say that at your stage of understanding here, we're going to say that these areas show infiltrates of inflammatory cells in the liver. They might be predominantly in the portal areas, but they can also be within the liver itself, like here, for example. Let's just call this hepatitis. Now, do you want to call it acute hepatitis again? This is another trick question. Do you want to call this acute hepatitis, or do you want to call it chronic hepatitis? Well, I think you'll agree most of these cells are lymphocytes, so you might be tempted to call it chronic. But remember, this is if it's caused by a virus, okay, this could be a acute viral hepatitis clinically, and like many other viral infections, even though it's acute clinically, it might be characterized by the types of cells that battle viruses, which are lymphocytes rather than neutrophils. That's why in a bacterial infection, you might have an increase in your neutrophils. In a viral infection, you might have increase in your lymphocytes. And that's just a general principle that has a lot of exceptions to it. Okay, let's leave it. And let's go into the world's most normal lung. Oh my God, how could you get a more normal lung than that? You can see there's three kinds of holes. There's holes that are lined by epithelium. Those are bronchi or bronchioles. There are holes which are lined by blood, and those are veins or arteries. If they're thin wall, they're more likely to be a vein, of course. And then there's holes that are just look like a little honeycomb pattern, and they're extremely tiny. Those are the alveoli. Okay, so if you want to remember all of the possible names of the cells in the lungs, knock yourself out. But if you want a quick pattern recognition, just look at a lung and say, I could see the air holes that are big, the bronchi or bronchioles. I can see the air holes that are small. And then I can see holes which contain blood, and these are the vessels. Take a quick pick, because this is the world's most normal classical lung. Now let's take a look at a lung again. And you say, well, is this a lung? I don't know. I don't see too many air holes. But you do see over here in the northwest that there are still some alveoli, don't you? See? But look, the alveoli look like they're starting to fill up with cells. What kind of cells do you think are filling up these alveoli? Well, let's blow it up. That's why we have a microscope, okay? So I'm going to ask you, are most of these cells that you see here neutrophils or lymphocytes? Because if you say neutrophils, which is the correct answer, then you have an acute pneumonia. It's as simple as that. Now, there's a lot of different kinds of pneumonia, and we're going to see a lot of different patterns, when we talk about lung diseases. But this is acute pneumonia. What else can you say about this lung? Well, there are some areas in which you don't see alveoli at all, and it looks like it's almost entirely neutrophils. For example, how about if we look at something like this area here. In this area, not only do you see almost predominantly neutrophils, but you can see they're starting to even replace and destroy the alveolar walls. So you would probably call this the same thing you would call anything that is predominantly neutrophils. You would say this acute pneumonia probably has abscesses, or at least starting to develop an abscess. And hold on, maybe we could even find like a bigger area. If I recall when I was looking at these last night, oh yeah, take a look at this area down here. We're going to blow up this little area in the southwest. And look, there's hardly any alveoli at all. It's all neutrophilic infiltrates. This is a microabscess. Why am I calling it a microabscess? Because it might not be big enough for you to see with your naked eye. If it was, then you would just call it an abscess. But if you call it a microabscess, it's probably going to be an abscess that you could just see predominantly with your microscope. Look, 100% neutrophils. That's an abscess. That's what every abscess in the world looks like, no matter where it is. Okay. Oh, we want to move on a little bit. Here is the world's most normal pancreas. And I think you'll at least agree that it's a exocrine gland. It has ducts between the lobules. It has ducts within the lobules. You might say, well, how do you know this is not a salivary gland rather than a pancreas? Why? Because you also see these little round areas that do not look like they are exocrine. They look like that they are just vascular, but they don't have acini. So that's islets of Langerhans. So does a pancreas look like a salivary gland, like a parotid gland, let's say, with the exception of having islets of Langerhans? Yeah. So this is the world's most beautiful and normal pancreas. Let's take a look at it again. Look at nice definition of the lobules. Got some ducts here between the lobules. You got some intralobular ducts. And you say, wow, this is really good. This patient has a normal pancreas. Now, let me show you something weird here, because this is going to be a little bit of a variation of what we've been talking about. Let's take a look at this pancreas. And you go, whoa. Well, maybe I see some exocrine areas, but I see fat, and I also see areas that don't even look like they're cellular. They look like they might be digested or necrotic. This is acute pancreatitis. And I know what you're thinking. You're thinking, well, if it's acute pancreatitis, shouldn't it have a lot of neutrophils infiltrating it? Yeah, that's possible. But guess what? Once this pancreas is damaged acutely, it releases all of its digested enzymes into itself. And now you have what doesn't look like a normal pancreas anymore. You have what looks like a partially digested piece of meat that came out of the patient's stomach. This is what they call autodigestion of acute pancreatitis. It can also auto-digest the blood vessels, and that's why acute pancreatitis has a very, very high mortality rate, because the whole pancreas, including the blood vessels in it and around it, could be getting destroyed. Well, what else does it do? Well, if a pancreas normally has a little bit of fat, and now you are releasing enzymes like lipases, which break up neutral fats, and the fatty acids combine with the sodium of the blood or the tissue, you now have soap or saponification, because the fats in and around the pancreas are being broken up and the fatty acids are combining with sodium to form sodium stearate. And in case you didn't know it, regular soap is predominantly sodium stearate soluble. Calcium stearate isn't, and that's why you may have calcifications as it becomes more chronic. Okay, are we near the end? Yeah, we are. I thought we were going to be rushed for time, but I don't think we are. I think we'll be able to get you out of here even before 11. Are you ready for the world's most normal skin? Here it is. You can see the epidermis. You can see the superficial dermis, which they call the papillary dermis. Then you can see a denser connective tissue, the deeper dermis. You could see sweat glands. You could see hair follicles. And not only can you see the eccrine sweat glands, but you can see these larger sweat glands called the apocrine sweat glands. So because you know you have basically apocrine sweat glands only in places like your armpit and your groin, that this was either from an axilla or a groin. And here, if you don't believe me, let's take a look, first of all, at the easy part. We have a keratinized, stratified squamous mucosa. So that already makes it suspicious for skin. Now, in addition, we have hair follicles, and the hair follicles have sebaceous glands at their base. And in addition to that, you might be able to find some eccrine sweat glands. Oh, like that could be the duct of one, but these sweat glands that you see here are apocrine. They have more of a smelly secretion. That's why the worst parts of your skin to smell are your axilla and your groin area, because they secrete fatty substances, not just water like the eccrine glands do. By the way, here is a eccrine gland, and here's an apocrine gland. So big deal. So it's skin. So what? So remember, this is basic pathology we're learning. This is nothing fancy. So you got skin, epidermis, dermis, sweat, sebaceous glands, and a little bit of fat underneath. Big deal. What am I going to show you now as a basic disease process of skin? And when we get to skin, we're going to look at probably 30 or 40 different types of patterns. But let's take a look at this one, for example. You got skin again, and I think you'll recognize it. Yep, you got your epidermis on the bottom. You got your dermis right underneath that, or in this case, it would be above. You might have some sweat glands here, but that's not the thing that gets your attention. What gets your attention are these big balls here. Here's a big ball, here's one, and here's the biggest one. So let's take a look at these big abnormal balls, which look like they involve not only the dermis, but perhaps even the subcutaneous fat, which this is over here. So let's blow it up. And let's blow it up some more. And bingo. Once again, you have inflammatory cells which are predominantly lobulated. So what do you call an infiltrate of inflammatory cells which is predominantly lobulated anywhere in the body? You call it an abscess. And let's not get any fancier than that. We're not going to theorize what caused these or what it might be secondary to. From a very honest point of view, you could say you have a skin in which you have multiple abscesses in the dermis and almost extending to the epidermis even. That thing could rupture and drain through the skin. You might put a needle through here just to drain that pus. And then it also extends just about right into the subcutaneous fat as well. So let's make a very honest diagnosis here and just call this abscess in the skin, or abscess in the dermis, or pus within the abscess material, okay? Or the pus is the abscess material. Okay, what am I going to show you here? Yeah, this is something that we talked about with basic pathology as well. I'm going to show you another skin. Well, right away, going backwards, you can see the subcutaneous fat. You can see the dermal fibrous connective tissue. Excuse me. And then you can see the epidermis here on the left. Okay. So let's look at it. Oh, so you can see epidermis, it's keratinized. And then you see these black little things in the dermis. Like there, like there, like there, like there. All these black little particles within the dermis. Let's blow it up and try to figure out what it is. Well, what if I told you that these little black particles are almost entirely within macrophages, because you see them as close as an inside of macrophage nuclei. We're saying, well, there's macrophages chewing up black particles. And what could that be? Does anybody want to guess yet? It's probably something that many of you may have if you're the younger generation. This is a tattoo. This is the introduction of ink particles through a needle into the dermis of the skin, causing it to be pigmented and also grossly causing it to look black or whatever color they go in. Now notice this. When you look at the skin here, it does not look like the skin is entirely black. You just see stippled black particles here and here and here and here, even though you just see tiny little black specks. If you were to look at the skin on the person, it would look black. If it was a person with white skin, it would look black, okay? Or maybe they would inject red particles or green particles. So this is what they call an exogenous pigment being chewed up by macrophages, okay? What's another exogenous pigment that can be chewed up by macrophages? Well, how about the soot or the smoke particles or the anthracotic particles that you breathe in the air? Aren't they chewed up by the macrophages in your lung also? And can't they go to the pulmonary lymph nodes and other lymph nodes? And they could make the lung lymphatics, especially the subpleural rich lymphatics, look black. And they can make the pulmonary lymph nodes look black as well, also with this very, very dark pigment. But this is probably not anthracosis, because I doubt if this guy was breathing through his pores or his sweat glands. This is a classical tattoo. But anthracosis is another classical example of an exogenous pigment being chewed up by macrophages. Hey, guess what? We only have 2 more cases, so I'm not going to keep you late after all. First, I'm going to show you the world's most normal thyroid. There's nothing else in the body that looks like thyroid except for thyroid. So it's very easy to recognize. These are all thyroid follicles. They're filled with colloid. They're lined by, probably cuboidal type cells. And every now and then you might see a cell between the follicles, like here, which they might call it interfollicular cells. So whereas these cells are lining the thyroglobulin follicle, the cells between the follicles are a little bit lighter, and they're called the interfollicular cells, or the C cells, or the light cells. They go by various names. We'll call it an interfollicular cell. And look, there's probably another interfollicular cell. And there's definitely an interfollicular cell. So whereas these cells are storing or making the thyroid hormone these cells are making the calcitonin, okay, which counterbalances parathyroid hormone. Take a quick look. Look at that follicular pattern. Nothing else in the body except thyroid. Looks like thyroid. Actually, there are a couple of minor exceptions, but for today's purposes, let's just say this is classical thyroid. Bingo. Now we've got our last slide here, and you're going to say, hey, this does not look like thyroid. This looks like a lymph node. What are these lymph follicles doing within the thyroid follicles? So look, we have a few remnant thyroid follicles filled with thyroglobulin, or colloid, so to speak. But then we have these lymphoid follicles infiltrating and surrounding. So now we have lymphoid follicles and lymphocytes infiltrating the thyroid gland. Why would that happen? Well, maybe the body was reacting against its own thyroid gland. Maybe you could find anti-thyroglobulin antibodies in this patient's blood. So this is autoimmune thyroiditis. It also goes by another name, named after a famous Japanese doctor, Dr. Hashimoto. So probably in the literature today, you're probably more likely to see the term autoimmune thyroiditis rather than Hashimoto, but they're the same disease. And how do you make the diagnosis of Hashimoto or autoimmune thyroiditis? Well, you have to see lymphoid follicles within or surrounding thyroid follicles. Just like with the adrenal gland. Remember, we said that the adrenal gland was lymphocytes attacking the adrenal cortex, so you could call that autoimmune adrenalitis, but you could also call it Addison's disease. So the same thing with the thyroid. You could call this autoimmune thyroiditis, or honor Dr. Hashimoto and call it Hashimoto thyroiditis. Well, you know what? We're done. It's not as long as I thought. I'm happy that we were able to go through all those cases, and I think it was very appropriate. Oh, here, maybe you'll let me see my face. I don't think I have much to say anymore, though. I think it was appropriate that we were able to discuss all of the cases which were demonstrable of the previous 7 or 8 chapters that we discussed already. So in the old days, I used to like to give more labs, because when I went to medical school, we almost spent as much time in lab as we did listening to lectures. But now we can streamline things, and by virtue of our computer microscopes, and maybe we don't have to do as many labs. So we don't have to smell the formalin either.